Good morning, good afternoon. I'm Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during your presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. Chrome is the best experience, and please make sure you're not behind a firewall, as this will prevent you from viewing the presentation. Our moderator as well as speaker today is Dr. Isik Su. Dr. Su is currently consultant in respiratory and ventilation medicine, Lane Fox Respiratory Service, Guy's and St. Thomas's NHS Foundation Trust, London. He is honorary senior lecturer, Faculty of Medicine, King's College, London. Dr. Su has published several articles and abstracts in peer-reviewed journals on topics relating to non-invasive ventilation on COPD. He is also a co-author and co-researcher on several studies on these topics with Dr. Murphy. Welcome.
Thank you very much indeed, Monica, for that very kind introduction. Good morning to you all, and thank you for coming. The title of today's webinar is Optimizing the Management of Chronic Respiratory Failure, Monitoring of Home Mechanical Ventilation. And speaking today on this very timely and important topic is an expert, a colleague, a friend, and very much a leading light in this field, Dr. Patrick Murphy. Paddy's a consultant and clinical lead at the Lane Fox Respiratory Unit at Guy's and St. Thomas's Hospital. He's presented primary research data at international conferences and been awarded grants by both the European Respiratory Society and the American Thoracic Society. His research interests involve respiratory physiology and respiratory support in acute and chronic respiratory failure, and he's published data in leading respiratory and general medicine journals, and he has contributed to both national and international guidelines in the field of management of respiratory complications of sickle cell disease and obesity-related respiratory failure. I'd like to just state that the speaker has disclosed the following relationships with ResMed, Philips Respironics, Fisher Paykel, and BND. I'd like to remind attendees that this activity has been approved for continuing education for 1 contact hour for nurses and RTs, and a link to obtain the credits will be available at the end of the webinar. Support for this education activity has been provided by Philips. And without further ado, I shall hand you over to my colleague, Dr. Murphy, for this important and interesting material.
Isik, thank you for the kind introduction, and it's a real pleasure to be here today to talk about what's, I think, an interesting, useful, and important topic for practitioners in respiratory medicine. So the topic has been given an introduction, but I just wanted to outline my plan and learning objectives for this talk. So really, I want to initially start with an overview of current practice in home mechanical ventilation, talking about the main diagnostic groups of chronic respiratory failure and why we manage and use home ventilation in those groups. I want to talk about the different pathways that we use for patients with home ventilation and how we can set them up. And then I want to move on to talk about more advanced and cutting edge elements of setting up pathways and remote monitoring of those patients in clinical practice. Now, I appreciate that the majority of the people attending this call will be aware of what home mechanical ventilation is, but sometimes it's important to look back so that we can look forward. This is a picture of rows of iron lungs that were used during the polio pandemics in the 40s and 50s. And I think this is really salient because this isn't home mechanical ventilation. Being ventilated in an iron lung with in a hospital setting, as was happening here, was what was necessary for a number of patients. But this was the real foundation of home ventilation. But it was about empowering patients and people to live lives outside of big institutions and within their own home. And so home ventilation has really moved forward hugely, so that we can actually deliver levels of respiratory support that previously requires hospitalization, but now can be delivered in the community setting. And so really this is what home ventilation moved to. And this is a picture from the feature film Breathe. And the lead character in this film, which is based on a true story about Robin Cavendish, who was a patient with polio, who didn't want to live in that sort of very clinical setting, wanted to live at home following his episode of polio, and he was fortunate enough to have a friend who's an engineer, and they built the first portable wheelchair with a combined ventilator, and that's what you can see in this picture here. And I'd recommend this as a film for anyone. And this is Adam Garfield, who's also played Spider-Man, playing this lead character. And interestingly, the film is produced by the Robin Cavendish's son, Robert Cavendish, and I do think that lends a real realism and passion to the story that's told. And I'd recommend that for everyone. And so that's home ventilation. I think it's an inception, but this is home ventilation, I think, as we like to practice in today's medicine. And this is one of my patients who was doing the coast to coast. So that's a transition across the United Kingdom, a much smaller journey than a coast to coast in the US, but still a reasonable undertaking in his powered wheelchair. And that's him on the left-hand side of the screen as you look at it. And on the right is him on the top of the Millennium Dome in London. And really, home ventilation is really not just about the home, but it's empowering patients to live their lives and be parts of society and contribute to the community. And again, this is another one of my patients who you can see there is tracheostomy ventilated, so 24-hour invasively ventilated, and that's him there with his son at a football match, doing what all of us should be doing with our Saturdays and Sundays, spending time with our family. The photograph next to that is him with his wife at a wedding when they were, up in Scotland. I think what I learned about this photo when I asked Lee to send it to me, it is, for those of you who are very eagle-eyed, you'll see just behind Lee's ear there is the connector for his ventilator, because as it turned out, in his own words, he was too vain to have the ventilator connected for the photograph, so he didn't want it, but his wife was sensible enough to know that she didn't want it very far away. So I learned something very important, which is that Lee can hold his breath for as long as it takes to take a nice photograph, but probably not for much longer. So hopefully, we've set the scene that home ventilation is of vital importance, I think, to patients with chronic respiratory failure, to allow them to lead, active, lives. And when we think about those patient groups, really, for us, we've got three main groups of patients that we look after. Those patients with obesity-related respiratory failure, which is really where there's a huge amount of increase we see in our workload, probably accounts for about somewhere between sort of 40% to 45% of our workload. Patients with airways disease, or principally COPD, a little bit of bronchiectasis, which takes up about sort of 25%. Of our workload, and then those patients with neuromuscular disease, which take about 30% or so of our workload. And so really those are the three large diagnostic groups, and I'm going to deal with them as we go through this talk, to talk about the evidence for home ventilation in these groups and how we can deliver home ventilation. It's not just the theory, but some of the practice as well. This is just really to stress the point that chronic respiratory failure, is a heterogeneous disease, and this is the survival plots for patients that we set up at the Lane Fox unit with different causes of chronic respiratory failure. And you can see the sort of very steep blue line where the mortality is very high, represents those patients with rapidly progressive neuromuscular disease. So that's typically motor neurone disease, or ALS as it's often referred to in the US. But you'll see actually those patients with airways disease, again, the mortality tends to be fairly high. Whereas those patients with slowly progressive neuromuscular diseases, such as the muscular dystrophies, the outcomes can be very good. And similarly, those patients with obesity-related respiratory failure, again, the outcomes can be excellent. Now, thankfully, given the current economic climate in the UK and elsewhere, it doesn't look like I'll be out of a job anytime soon, and the prevalence of chronic respiratory failure is increasing, and the number of cases that we're seeing year on year is going up. These data are a little, almost a decade old now, but actually this trend has continued, and we're now establishing somewhere between 250 and 300 patients per year on home mechanical ventilation. So this is an increasingly important area that I think we all need to pay appropriate attention to, and to make sure our patients receive the real best quality care they can. So moving on really to talk and focus a little bit on obesity hyperventilation syndrome for a moment. And this is a triad of obesity, daytime hypercapnic respiratory failure, and sleep disordered breathing, which for the majority, 90-95% of patients, will be obstructive sleep apnea, but for a minority of patients may be pure hypoventilation. But what's important is that this is a diagnosis of exclusion. So you need these three key features, but you also need to not have another disease that could cause respiratory failure. So you can't have severe COPD, you can't have a neuromuscular disease, and I think that is important, that this is a syndrome rather than a specific disease, and really the underlying pathophysiology isn't always understood, but we need to always examine for other causes of respiratory failure in a patient with obesity before we attribute it to the obesity alone. Now, why do we deliver home ventilation in these patients? Well, actually, the commonest reason for presentation is that these patients feel sleepy, and actually home ventilation significantly improves sleepiness here, and this is when it's been objectively measured by the Osler test, which is a form of a maintenance of wakefulness test. So you can see significant improvements in those patients provided with home ventilation compared to those patients who are not in a randomized fashion. So significant improvement in symptoms for sleepiness. Also significant improvement in other forms of health-related quality of life, principally breathlessness, and a range of health-related quality of life measures you can use, whether it be functional aspects of sleep or more generic quality of life questionnaires such as the SF-36. These patients have severe morbidity, they have significant symptom burden, and that symptom burden is relieved by home ventilation. So it's important to the patient. Not only is it important to the patient, but it's important to the health system that we treat these patients, because actually they have high healthcare utilization, and we can reduce that healthcare utilization by delivering home ventilation. And we can also improve prognosis here, not in a randomized control study, but in an unrandomized cohort control study, looking to see you can see here with significantly higher mortality, 23%, in those patients with obesity-related respiratory failure not treated with NIV, compared to those who were either eucapnic obese patients or hypercapnic obese patients treated with non-invasive ventilation. So it's important for patients so they feel better, it's important for the health system so we reduce cost, and it's also important in terms of long-term mortality. So what's the take-home message? Is this is an important therapy because it's important for all of these areas. Now, often we get asked for when we're talking about the management of patients with obesity-related respiratory failure, the question is often asked, well, does this patient need CPAP or do they need NIV? And there's a lot of good studies out there demonstrating that if you pick the right patient and you deliver the therapy appropriately, it doesn't matter. And by that, what I mean is that if you control the sleep disordered breathing, then actually it doesn't matter whether the mode of that support is either CPAP, simple 1-level pressure, or BiPAP, more complex 2-level pressure. If you control the sleep disordered breathing, that is the pathophysiological problem, and therefore you alleviate the daytime respiratory failure. And really, CPAP or NIV is not the right question, but it is how can we treat their sleep disordered breathing, and it needs to be whichever modality of positive airway pressure therapy does that. Well, how do we know if we have a patient in front of us? Do we just treat everyone with NIV because we know that will treat the minority of patients who don't do well on CPAP? But actually, we can manage to look at that, I think, from day one. And I think what's really useful is that the best predictor of treatment failure at 3 months was if the treatment didn't work at day one. And so that's really useful. And we can see here, looking at a measure of sleep disorder breathing. So this is the mean oxygen saturations overnight. And those patients who were uncontrolled on the first night were much more likely to be under controlled at 3 months. And therefore, we know if we're not controlling at the initiation of home ventilation, we're not going to be able to manage that further down the line. And therefore, it is really titrating that intervention at day one to make sure we control the respiratory failure and the sleep disorder breathing. And I think that's a really important message. So this is looking at what those predictors can be. So this is looking at a range of different parameters, looking at the nocturnal saturation, the PA CO2, so the arterial gas, either early in the morning or prior to treatment, and then the total sleep time under 90%. And you can see on each of these levels, those patients who had successful initiation of CPAP, who are demarked in blue, compared to those patients who had CPAP failure, denoted by ongoing hypercapnia at 3 months, are in red. And you can see on each of these parameters that those patients with failure at 3 months had worse outcomes on that first night of titration. So really, we can set some important benchmarks, and we can say, well, actually, if the mean saturation is above 90%, then you've got a good chance of having adequate control at 3 months. If the CO2 is greater than 7, your chance of success is much lower. Similarly, if your early morning blood gas is over 7, again, much less likely to be successful. And if your total sleep time under 90 is over 10%, then you're much more likely to not have control at 3 months. So we can use these factors during setup of home ventilation to make sure it's delivered adequately and effectively for this patient group. So really the take-home message is, if you're setting up home NIV, then really that first night titration is of vital importance. Get that right, the patient will have good control. Now moving on to patients with neuromuscular disease. I think this is an important area, and again, an area where there is good evidence, not randomized controlled trial, and I don't think there ever will be a randomized controlled trial of home ventilation in patients with neuromuscular disease, because overall, the general consensus is that these patients should be treated. But you can see that the outcome of patients, whether it is quality of life or mortality, is better when we look at those patients with home ventilation compared to those who do not have home ventilation. And I think there's a number of domains and parameters we can look at that demonstrate that. So if we have a patient with neuromuscular disease and chronic respiratory failure, or even slightly earlier, and with just evidence of sleep disorder breathing, then really we should be treating that with home ventilation. Now, I think it's important when we're thinking of patients with neuromuscular disease that we understand a little bit about the control of breathing during sleep. I'm not going to go onto this in detail, but there are changes in the upper airway, there are changes in respiratory pattern and muscle function, and change in the control of breathing. And these all make sleep a vulnerable time for the respiratory system. And for those of us who have adequate respiratory reserve, that isn't a problem. But for those of us who don't have adequate respiratory reserve, the system can become impacted and pushed over the edge into respiratory failure during this period. And this is a really useful time for us to check. And I think this is a really salient example of that. And that's because if we look at this patient who had polio, we can see that during the daytime, you can see that the respiratory oxygen saturations here would be 95%. So during wakefulness, I think really important to realize that these patients may have adequate oxygenation. So when you see them in clinic, you may not be concerned, but you can see quite quickly when this gentleman went into non-REM sleep, his oxygen sats dropped from 95 to 90%, and you may say, well, that's still not of a major concern. However, one can see quite clearly that when he goes into REM sleep and the rest of the respiratory muscles are paralyzed apart from the diaphragm, you can see a very profound, deep and prolonged desaturation. And this patient had severe significant sleep disordered breathing. And even if he is not yet in daytime respiratory failure, it's really important to intervene. And there's a wealth of data that helps us look towards that. We can see here data looking at the change in measures of respiratory muscle function and daytime CO2, that those measures of respiratory muscle function start to deteriorate prior to the development of daytime hypercapnia. And I think that's really important because that allows us to intervene sooner. This was a really important study, small in number, but I think making a really valuable contribution. So they took those patients with mild, slowly progressive neuromuscular disease, so not MND, but things like muscular dystrophy and chest wall disease or polio. And they took those patients and they made sure that they were daytime eukapnic, so not in daytime respiratory failure, but had significant sleep disordered breathing with hypoventilation. And then they followed them up for 2 years to see how many of them then had to start ventilation during that period. And you can see all bar one patient initiated home ventilation in the 2 years following documentation of an abnormal sleep study with hypoventilation. So we know that there is clear progression, and once a patient develops abnormal sleep disordered breathing with a progressive neuromuscular disease, we know we've got a window of opportunity to introduce and develop the idea of home ventilation before they develop a complication. The single patient here who didn't end up on NIV was a young patient with chest wall disease, and probably that reflected a change in the maturation between skeletal and muscle function. Again, looking at how we evaluate these patients, and actually, I think what's increasingly important is a simple home oximetry as a rough and ready screen, but actually what's clear is when we're evaluating patients with neuromuscular disease on home ventilation, that you need a combination. And actually, there's a couple of good papers from both the Norwegian group and the group in Lyon in France, looking at different methods of assessing the efficacy of home ventilation using just clinical daytime tests such as spirometry and arterial blood gases, using overnight oximetry, using transcutaneous CO2, or using a combination of ventilator download software and home oximetry. And what was clear is that without a combination of these factors, you would misclassify people as having adequate control or not being in an at-risk group. And so you need a combination of transcutaneous CO2, which is much more sensitive than oximetry alone, as well as clinical review in the daytime and NIV software. And that combination had the highest sensitivity and specificity for diagnosing and spotting patients with clinically important control of their sleep disordered breathing. So I think that's a real important message, that any single test is likely to miss patients, and you need a combination of data, both from home tests, from in laboratory tests, from NIV data, and from clinical review to make sure you correctly stratify these patients into whether they have control or uncontrolled sleep disorder breathing on their home ventilation. And again, this is data from those same study, just with a little bit more accuracy, showing here the numbers of patients that you might misclassify. So here between 20 and 35% of patients who would be misclassified as having adequate control if you didn't use a combination of these factors. And that's significant numbers. So I think really pushes home the importance of a multimodal assessment for this patient group. So what's the take-home message? It is really, if you have it available, transcutaneous CO2 is more sensitive and more specific than simple oximetry. But really, we need those techniques in combination to provide best care for our patients. One might say, well, is it important to identify whether these patients have adequate control of hyperventilation? Is there any clinical sequelae or clinical consequence of that? And actually, there's good data in patients with neuromuscular disease that if there is residual hypercapnia, and here in this study, they define that by a transcutaneous CO2 of over 49 millimeters of mercury for more than 10% of the night, then actually you can see very clear separation of those patients with good control and with poor control, where there was an increased risk of respiratory exacerbation, an increased risk of ICU admission, and sadly an increased risk of death in those patients who are poorly controlled. So actually, it's really important that actually not only do we set up patients, but actually we monitor the efficacy of ventilation using this multimodal approach, and that we correct and treat sleep disordered breathing when it's identified, because those patients whose respiratory failure and sleep disordered breathing goes unoptimized have worse outcomes. And now I'd just like to just move across to COPD, the final of those diagnostic groups, and talk a little bit about the data to support home ventilation in that group. And I think if we were giving this talk 3, 4, 5 years ago, actually home ventilation for COPD was probably less well known. It was less well received. And you can see here, actually now within the gold guidance as a grade B level of evidence, that those patients with chronic hypercapnia and ongoing exacerbations and respiratory failure should be considered for home ventilation. So this is now an increasing part of the standard armamentarium for those clinicians looking after patients with COPD. Why should we do that? Well, because the physiology is better. You treat their chronic respiratory failure. Not only is their physiology better, but the patient's quality of life is better, or at least it's no worse. And that's over a range of different quality of life measures. Those patients have fewer exacerbations, and we know that is one of the major events for patients with COPD. And if you choose the right patient group, actually you delay time to significant exacerbations, and you reduce the absolute number of exacerbations. So really important for patients. If it's coupled with pulmonary rehabilitation, then actually you can improve exercise capacity. So you know, the benefits I think are significant, and there are some data, you know, slightly inconsistent, but actually suggestive that we may be able to increase them, or sorry, decrease the mortality, increase survival in this patient group. So there's a range of benefits now, I think, that have been proven by a number of different studies, and I think where this was historically overlooked by clinicians looking after patients with COPD, I think that can no longer be the case. And there's sufficient evidence to mean this should be standard practice for those patients with chronic significant hypercapnia. Now, with all things, NIV is a therapy that works if you use it, rather than if it's you know, just left in the cupboard. And the data suggests that there is a you know, a significant effect of that. So those physiological, clinical effects are enhanced for those patients who are compliant with treatment. So better improvement in respiratory failure, bigger reduction in exacerbations, and a more convincing impact on mortality. So really, the take-home message is, and I think this is well adopted in Europe, and my understanding is that it is increasingly used in the US, that for the right patient, those with chronic significant hypercapnia and CO2s of over 7 in the convalescent period should be offered home ventilation, because it makes a significant difference to outcomes. Now, really, in COPD, one of the reasons why this is controversial is there was a number of studies many years ago that didn't show improvements in these clinical outcomes. And if we look at some of those studies, we can see that the pressures here that NIV was using was relatively low, 12, 13, 14 centimeters of water. That the titration strategy wasn't to improve respiratory failure, but was to other factors. So you know, reduce work of breathing, improve CO2, or to achieve adequate sleep. Whereas we contrast that with those studies who used a higher intensity approach of non-invasive ventilation. So you can see here 3 studies, 1 non-randomized and 2 randomized, using significantly higher pressures, so 22, 24, and 28 centimeters of water, using a titration policy that delivered and managed respiratory failure. You can see that there are improvements in clinical outcomes, and I think that is really important. Now, this was initially termed high intensity NIV. I'm not a fan of that term, because the absolute pressure is not the aim. The aim is not to push the ventilator up. The aim is to ventilate the patient. And so really what this is physiologically targeted NIV setup. And it's really talking to the same message that we've spoken to already in those patients receiving home ventilation with neuromuscular disease or with obesity, that the problem is sleep disordered breathing and respiratory failure. So you need to deliver the titrated therapy to that problem. And I hope that's a really important message that everyone can take home. Now, often people say, well, if you use very high pressure ventilation, that patients won't use the ventilator. Actually, the evidence is not only do you control respiratory failure, but the patients sleep better, and actually they use the ventilator more than if you were to give them low pressure NIV. And that's because you're reversing the physiological impact of the chronic respiratory failure, and therefore you're making them feel better. And it's easier to use something that makes you feel better, because we know whether CPAP or NIV, it is a physical therapy that patients need to buy into, and they need a reason to buy into that therapy because it's not easy. So again, we need to say in these patients that we need to reverse or at least control respiratory failure, and that needs to be the target of a successful home setup in these patient groups. The absolute strategy, whether that's with a high backup rate, a high pressure, or other more exciting modes of ventilation, I think really depends. And again, it's not the mode that's important, but it's delivering that therapy in a way that's satisfactory for the patient. And one way that we are using technology increasingly in our practice is the use of auto-titrating modes. And very simply, those modes measure the estimate the tidal volume that patients are breathing, and they titrate the inspiratory pressure support up or down to try and achieve the tidal volume that the patient needs, and therefore prevent hypoventilation and prevent desaturation. And there's a range of these strategies, and not only to optimize pressure support, but increasingly they're also used to maintain airway patency, and those that auto EPAP to keep you on that optimal part of the curve where the airway is maximally open, and therefore you can deliver pressure more effectively. Now, what's the evidence for these modes of ventilation? Well, I think what's clear is that there's fairly consistent, irrespective of the model of the ventilator or the manufacturer, and there are differences between each of the manufacturer's algorithms, but there's some consistency across the literature, and that is that the patients have improved sleep quality with auto-titration compared to standard modes of non-invasive ventilation, and that's both subjective and objective sleep parameters. That there's improved ventilation, so you get better control of chronic respiratory failure, and that does also appear to lead on to improve compliance with non-invasive ventilation. So these are really important parameters. So if you've got patients where sleep quality is low, where respiratory failure is difficult to control, or where compliance is an issue, switching to an auto-titrating mode of NIV may well be beneficial for that patient. And we can say fairly clearly that those modes are safe and effective. So how can we utilize different pathways to set up patients with home respiratory support? These data are relatively old, but this was some of the first data back in the sort of mid-2000s, demonstrating that actually you didn't need to bring a patient into hospital to set them up on home ventilation, that you could effectively improve parameters such as CO2 by delivering NIV in an outpatient setting. And so there's some evidence around safety and efficacy. And there's a little bit of data to suggest, well, that unsurprisingly, patients find that more convenient. So that patients largely prefer to come to the outpatient setting to have their ventilators set up rather than come into hospital for an admission. Broadly speaking, the other parameters here were very similar in terms of what the patient felt. I think what's important is that most of these studies dealing with setting up home ventilation in outpatients excluded obesity-related respiratory failure or sleep apnea, or included very few patients with that diagnostic group. And that's because titrating NIV to maintain upper airway patency is more complex if you don't use a sleep study. However, with auto-titrating modes, that now is a tenable option. And that's what we did in a study that we published only a couple of months ago in thorax. And this looked at patients with obesity-related respiratory failure who were new de novo setups for home ventilation. And we randomized those patients either to have an admission to hospital and be titrated on a standard fixed bi-level device, or to be set up as an outpatient using an auto-titrating device that auto-titrated EPAP to maintain upper airway patency, as well as titrating IPAP and pressure support to maintain adequate ventilation. We used a setup algorithm, both as an inpatient as an outpatient, to try and standardize those approaches. And that we also looked at an outcome, I think that's important. So it was both clinical and cost effectiveness. So we looked at CO2 for clinical efficacy, and we looked at cost effectiveness using health-related quality of life and cost of intervention. What we demonstrated was very clearly that the outpatient mode using the auto titrating device was equally efficacious. Not only that, but actually it wasn't just similar, but actually we had a non-inferiority margin of 0.5 kilopascals. So quite clearly there within that non-inferiority margin, and in fact, actually with a trend towards some slight better improvement in gas exchange in the patients set up as outpatients rather than as inpatients. So no evidence of any safety signal, which is what we expected in these data. I think what was interesting was actually what we also showed was that the total costs were very similar. So whether you set these patients up as an inpatient or as an outpatient, the overall cost over the duration of the study for those two modes or methods of setup were very, very similar. Maybe people will say, well, that contrasts, and how do we compare that to other published data which suggested that an outpatient setup was significantly cheaper? And this is one of those other studies here where they set up patients either in the outpatient setting or as an inpatient. And what you can see here is they had a 6-day stay to establish home ventilation, and that led to home ventilation setup in hospital being just less than twice as expensive as setting up as an outpatient. But 6 days isn't our usual practice to set up home ventilation in the UK, which is usually a 2-day stay. And actually, if you reduce the cost in this study by a third for the inpatient setup costs, and then you'll see quite quickly that those costs end up being very, very similar. So about 1,500 euros both to set up as an inpatient or as an outpatient. So again, similar to the data that we had in our study, if you set patients up quickly in an in-lab setting, that actually the outpatient setting is not substantially cheaper. And there are a couple of reasons to think about that, because one would think that an inpatient setup would be more expensive. But actually what was very interesting was that the contacts patient had following an outpatient setup were higher. And one can imagine that's the case, that if a patient is in hospital for 48 hours to have a sleep study, be titrated on an IV, there's quite a lot of contact time with the staff during that period. And so you can see here that in the patients who were set up as outpatients, that although the inpatient, the setup cost was lower, there was extra costs over the period of follow-up, because patients contacted the home ventilation teams more often and were more likely to have a readmission for retitration of their ventilation. So I think really important data to suggest that actually one can choose these pathways in a way that works for your service. Now, one can go a step beyond setting a patient up as an outpatient, and you can move towards setting patients up in their own home. And this has been done in 2 studies in the Netherlands in patients with neuromuscular disease and patients with severe COPD. And one can see in both of these studies a significant cost saving for those patients set up in the home setting rather than those patients set up in the inpatient setting. And here, somewhere between sort of 3,000 and 5,000 euros, depending on which patient group. I think what's really important to also realise 2 things. One, that again, the inpatient admissions were fairly long, between 5 and 7 days. So maybe that doesn't reflect practice everywhere in the world, but it was practice in these studies that were both taken part in the Dutch healthcare system in the Netherlands. I think what's also really important to realize is there's quite a lot of technology involved in this. So they used a transcutaneous CO2 device that was provided to the patient that had a remote monitoring link where both the ventilator, the transcutaneous CO2 device, both transmitted those data to the home ventilation center. And each day that the home ventilation nurse would review the sleep study, advise the patient on ventilator settings, and decide whether the ventilator had been adequately set up. And the home setup for patients took between 5 and 30 days. So actually quite intensive and involved for both the patient and for the respiratory therapist to be involved in contacting those patients on a daily basis for a prolonged period of time. And I think the infrastructure probably isn't there in lots of places to deliver that. However, it is an option if that technology can be incorporated into our routine practice. So I think what's the important take-home message from here is that home NIV, needs to be undertaken by a specialist centre in an MDT setting. That control of sleep disordered breathing and reversal of hypercapnia is the real aim of therapy. But how you deliver that, whether that is using standard fixed bilevel, whether that's using auto-titrating modes of non-invasive ventilation, whether that's setting up as an inpatient, as an outpatient, or even in the patient's own home. Each of those strategies can be equally effective as long as they're titrated and monitored appropriately. It's not the intervention that matters per se, but it's how it's being delivered and whether it's being delivered effectively to manage that chronic respiratory failure. Now, moving on, and this segues, I think, quite nicely into remote monitoring, which is the technology they were using in that part of that Dutch study, and that really, hopes to again, I think, build on that pioneering spirit of getting patients out of hospital, getting them back to their own home, and making sure that care is delivered in a home community setting, not in a hospital setting. And really, we can use that remote monitoring in a bi-directional way, so we can update patients' ventilator settings, we can get efficacy data, and we can communicate via them. We can use them for setup, but we can use them also for optimization and routine reviews for patients on home ventilation. I think what's really interesting is, as I said, that we know that the level of data that we use, and I alluded to this earlier on, how we measure efficacy of ventilation can vary, but the proportion of patients is somewhere between 20% and 50% that would be deemed to have suboptimal NIV if we just went out and looked at patients who were already established on home ventilation. And so the question is, how can we best measure that? And again, in this study, a multimodal approach was the most effective. Does that remote approach impact on how we manage patients? And this is a study from the UK where they used a remote strategy to look at patient outcomes. And you can see here that following a remote review, there was a significant improvement in compliance with home ventilation. So the patient had a remote consultation with a respiratory therapist who reviewed data from the patient's ventilator, adjusted their ventilator, performed an interface review if it was appropriate because there were high levels of leak. And you can see that actually that had a positive impact on that patient in terms of improvement in compliance. So again, suggesting that we can use some of these remote data to improve patient outcomes by improving patient use of ventilation. There's a little bit of data to suggest that actually maybe we could use those parameters from remote settings to predict exacerbations. These data are relatively novel, but one can see here that looking at different ventilator parameters, whether that is a respiratory rate, whether it's time on ventilation, or whether it's a percentage triggering, that there are changes in the lead up to and during an exacerbation that may be able to trigger an alert to a clinician to review a patient who is at risk. Those data have tried to incorporate into telemonitoring programs, and there is evidence that they can be used to target at-risk groups. However, there is a very high false positive rate and also a false negative rate. And therefore, although these strategies can be used, there are no good data yet to suggest they're cost effective, and therefore I think we need to implement them with a great degree of caution, and only where we really think we can intervene and make a benefit. And I'm not sure that the data there support the use of these in patients with high respiratory risk. These are UK data looking at patients who were provided with home monitoring and those that weren't. And you can see actually no significant difference between these Kaplan-Meier plots in terms of exacerbation frequency. And actually there was a trend towards higher exacerbations and higher patient and higher clinician contact time in those patients who had remote monitoring because of that false positive rate. So I think really excellent data that if used in the right way at a clinical review to improve patient ventilator synchrony and patient ventilator compliance, but it can be worthwhile, but using in a blanket way or as an exacerbation prediction tool, I think probably the data aren't there. this is, I think, just really talking to that same point, looking at how you could use different algorithms and algorithm implementations. And obviously, depending on how you set those algorithms, depending on what the level of intervention and interaction can be. And this is data that we've published in abstract form so far and is currently under peer review, where we asked a group of clinicians to provide different levels of cutoffs for what they felt required triggering in these different areas for remote monitoring, and what that intervention would be, whether it be a remote consultation or a home visit. And then we ran those algorithms through 100 patients of ours whose data we had, and then we looked at the cost and number of alerts, and you can see a huge variety here, 11 different clinicians, where the number of alerts, depending on what threshold their personal thresholds were set at, between 20 and over, and sort of 250, and therefore a cost, per patient, depending on which model the clinician chose, between $11 per patient to over $100 per patient. So I think really important to know that these data are there, but I'm not sure we know yet how we can best incorporate them into clinical practice. And we need to be careful in how we do that, because as can be seen here, if you implement the wrong threshold when you bring these in, the cost could be really, really substantial. And so I think we need more data, and we need that data to tell us and inform us who needs intervention and how that intervention should look, to make sure that that intervention is cost effective in those patient groups. So hopefully that's given a good overview around home mechanical ventilation, and we've spoken about the three main diagnostic groups. We've talked about the evidence to support home ventilation in those three groups, what the clinical benefits are, and why should we should be delivering home ventilation in those groups. We've talked about the importance of titration of home ventilation to control sleep disorder breathing and respiratory failure in each of those groups, and the data that supports that it isn't just giving a patient a ventilator, it's establishing it correctly. And making sure that it treats the underlying pathophysiology. We've talked about inpatient and outpatient setups, and actually that these pathways are equally efficacious in terms of clinical benefit to the patient, and actually very similar in terms of cost. And therefore the pathway chosen should be the model that works best for your practice and for your patients. I think we've talked about the range of remote monitoring that can be used to monitor home ventilation, both as clinical review, simple oximetry and arterial blood gas, more advanced such as transcutaneous CO2, as well as the role for remote monitoring software. Talked a little bit about how that remote monitoring software can be utilized to benefit patients in terms of compliance and software. And we've also talked about the algorithms and how they can be refined. We also touched about novel technology in terms of auto-titrating ventilation. So I'd just like to thank you very much for your time, and I'd like to hand back to my co-host and colleague, Dr. Sue, who will move on with the question session.
Paddy, thank you so much for that incredibly informative and factually very dense and data-rich presentation. I think modesty kind of prevented you from actually saying that you conducted many of those studies yourself, actually, and I'm really, really grateful to you for a really informative study. I've worked with you for over a decade, and I learned quite a lot during that talk, so very grateful to you. I'd just like to remind colleagues on the call that how to obtain continuing education credits from saxtesting.com. And just to remind you that this educational content is provided and supported by Philips. I'd also like to inform you that an archived and on-demand version will be available on betteroutcomes.org, and the online version will be accredited for nurses and RTs. Now, before we move on to questions, and there are some fantastic questions actually, and unsurprisingly, from a very stimulating talk. I mean, one question I had in mind, just while colleagues put their questions into the chat, is why not negative pressure? And I know there's been a lot of discussion about that over the decades, but why not negative pressure, Paddy? Just briefly, whilst colleagues are asking their questions.
It's a very good question, Isak. I think, like me, you've spent a little bit of time in the iron lungs, and so know what it feels like. What one will accept that actually it's a relatively comfortable form of ventilation, and in many ways better than having a mask strapped to your face. The principal issues are that for negative ventilation, you're either using the cuirass or the poncho wrap, which physically are quite big. So, the equipment is large, it's cumbersome, it needs to be custom molded in terms of the cuirass. So it is harder to roll it out, at high volume. I think also the technology was temperamental, and achieving a good seal difficult. I think it's also fair to say that obviously the iron lung is hugely impractical for most people, and I think that this is true in the UK, and I understand also true in the US, that the population are in terms of obesity only get headed in one direction, and negative pressure ventilation doesn't stabilize the upper airway. And in our patients with Duchenne, particularly those who are on steroids, with our older patients, with obesity-related respiratory failure, and even with our COPD patients, obesity is a problem, and therefore negative pressure ventilation actually can generate upper airway collapse and therefore worsen sleep apnea.
And thank you. And although we have until recently had patients on the iron lung, I think most would be grateful not to have to lie in this enormous clunking thing. But it's just important. Kind of the imagery of the iron lung is very powerful, isn't it? And I think it is important for colleagues perhaps who aren't so familiar with home vents to understand why we've moved away from that. Got a great question here, Paddy, from a colleague who asks. Again, very pertinently, these patients typically don't live in the cleanest conditions, and certainly that's often true of our patients who live in somewhat difficult circumstances in southeast London. And the question is, do you see an increase in respiratory tract infections and recurrent pneumonias or other infections?
I think it's a great question, and it talks to a really important topic at the moment, which is about poverty and the impact of poverty and health inequality. And as you say, we work in an area of London that has huge disparity in terms of wealth. And unfortunately, there is a very good correlation between living conditions and socioeconomic status and frequency of pneumonia. And actually, poor quality housing approximately doubles your risk of pneumonia. And there's a range of studies, in different healthcare settings, and that that sort of ballpark figure seems to be pretty consistent. And so we know the data are there, and I know I advocate for my patients who are contacting, in the UK, it's the local housing association for changes to the housing and accommodation to try and improve that, because it has a material impact on patients.
Absolutely, and I'm sure this is true kind of across the world and in the United States as well. But people are facing real challenges as well with paying their electricity bills, and that's often putting people off. Occasionally, we see patients whose NIV use has diminished as a result of cost and social deprivation. Now, we've got a further question here, and I have to say, I really in two parts, really. So the statements are, so this means overnight sleep study is very important before patients go home for good, mean oxygen saturations. So I think you'd agree with that. The only problem I've encountered is sometimes patients' cooperation. For example, taking off the mask, going to urinate, other staff disturbing. So that is something we see, isn't it? That patients who, despite having excellent NIV delivered, in many ways they interrupt themselves. And I guess the second part of that is that oximetry is important, but as you've alluded, it's the capnography and the combination of physiological measurements that's important. Would you have a response to our colleagues about that?
Yeah, no, I think it's an important question, Isak, and alludes to the reality of delivering these interventions, and that can be, I think, where some of this ventilator download software can be really helpful, and really incorporating those two sets of data together. I remember when I first started reviewing outpatient sleep studies, we'd be presented with an oximetry, and there might be a short period where there'd be very poorly controlled sleep disorder breathing, and we'd then be, well, do you think they took the mask off? Do you think they maybe got up to go to the bathroom? Do you think maybe there was just a lot of leak? And now actually we can bring up a contemporaneous data from the device going, oh no, actually there was significant leak at that point. They should see they should see the nurse for an interface review. Oh no, actually they've taken the device off at that point, and therefore we need to speak to them about making sure they use it for the full duration of the sleep. And I think it's really interpreting that data in its entirety, that if there's a period of sleep disordered breathing that isn't sleep disordered breathing, it's because the patient was off the ventilator, or they were doing something else, then actually, as long as you know that, you can exclude that from the part of analysis, or interpret it appropriately. So I think it's really looking at that, having all of those data available to make that interpretation. And as I said, that has made the review of those home studies so much more informative for me now.
Absolutely, but often the data can be overwhelming, and of course, as you've alluded, are there more intelligent, perhaps AI ways of integrating that data with novel algorithms that will then trigger to the to clinicians? Now, you and I, given that we normally work about 30 centimeters away from each other in our office, could talk about this for hours. But as it happens, we've got a very, very pertinent question actually here from a colleague, actually particularly in relation to where I'm at the moment. I'm speaking here from South Korea, where they've only been reimbursing home mechanical ventilation for the last 4 years. So the colleague says, thank you for this great review in HMV. Few governments in the world still won't fund NIV on COPD. The main reason is always lack of evidence, and I suspect you might disagree with that, Paddy, having published on this yourself quite prominently. From your perspective, in 2022, do we have enough strong evidence to support the coverage of NIV in the COPD population? Great question.
Great question. As always, a good answer is not a simple one. I think for the right patient, and so I think what we've got to do is learn from all of those studies. The reason why home ventilation in COPD is controversial, or was controversial, is there were a range of studies that showed it didn't work. But it didn't work because either the intervention wasn't right, or it didn't work because the patients weren't right. And so the patient needs to have respiratory failure, and it needs to be significant respiratory failure, so not a CO2 of 6.1 or 6.2, but significant at 7 or above. And the ventilator needs to be delivered in a way to treat their respiratory failure. And I think, yes, there is sufficient evidence. And as I said, the GOLD guidelines now rate that evidence as grade B, which is compelling for most people. We have published in abstract form, and hopefully will be shortly available as a publication, cost effectiveness data to suggest that not only actually does home NIV work for patients and all of the clinical data that I spoke about, but also it's cost effective, because delivering that home ventilation reduces exacerbations. Those data hopefully will be published within the next month.
Fantastic, Paddy. As always, there is more to come from you, as always. Now, we are just running out of time, but there are 2 questions, both on AVAPs. So I guess a very, very quick fire question on, have they considered using AVAPs average instead of just BiPAP, which you've alluded to and spoken about, and a further question about AVAPs AE for COPD or hypoventilation. And just maybe 15 seconds on this, Paddy, before we draw to a close.
So I think good question. So these modes of ventilation are available. As I said, the different manufacturers have slightly different algorithms. The data suggests that they are all relatively similar in how they manage and achieve ventilation. That all of the data suggests that they are as good as ST, and that there may be some benefits in terms of subjective sleep quality and objective sleep quality and control of ventilation and such compliance. Our practice, because there is obviously a cost implication to some of these modes of ventilation. Our standard practice is, as I say, to often use a simple bi-level device to start. But I think if you are running into trouble because the patient is less compliant, because there is uncontrolled sleep disorder breathing, or the patient is having sleep quality issues, then often we will then step up to the auto titrating algorithms. And as I said, the data is fairly robust now that those are clinically effective.
Now, we do have to draw to a close. Thank you so much, Paddy, and apologies that we couldn't address more questions. Thank you so much for an excellent presentation full of data, and I'll hand over now for closing remarks from Monica.
Thank you so much. We do thank you for attending this webinar. And as you can see on the screen, the survey will pop up immediately upon conclusion of this webinar, and you will be presented with an online survey. So please keep your browser open, and we do appreciate your feedback. And as a reminder, CE Certificate of Completion for nurses and respiratory therapists. To obtain your CE credits, visit www.saxtesting, that's S-A-X-E, testing.com/BO, and register at that site, and please complete the evaluation. And we thank you, and this does conclude our webinar for today. Again, a reminder, there is a survey for you at the conclusion. It will pop up immediately, and we greatly appreciate you being here today. And so we thank you again on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips. I hope you enjoy the rest of your day.